oblique fractures results in shortening of your intrinsic muscle resting length, which is not functionally helpful. And fracture angulation, talking just as a guide as in these diaphyseal fractures, starting from index to small. 10 degrees, 10 degrees, 20 degrees, and 30 degrees on the small is kind of a good guideline to just think about and use that to help you make your decision. And again, 10 millimeters of shortening, which in some series that said that you could accept that 50% loss of power, which is probably not going to be acceptable to most patients. Just a last slide on outcomes, just talking about basically what do we expect? Well, Dr. Stern showed that about 36 complication rate with fixation, open fixation of metacarpal fractures, but 76% good and excellent results. The range roughly is about 20 to 35% complications, most often notable stiffness, strength changes, and need for hardware removal. Dr. Mudgal and his group published a series with plate fixation and showed that 18 out of 19 of them patients had full active range of motion at 6 weeks, 1 delayed union in a smoker, and 2 plate removals. So overall, very good. So definitely is worth, the technique is worth doing and learning about it. So that's what I have. And now I'll stop sharing and we'll have Dr. Mudgal share his screen and do his presentation.
Thanks very much, Kim. I'm honored to be here today. And this is someone I saw in 2007. It was a 54-year-old female librarian who fell from a ground level fall and serendipitously had to be a primary caregiver for a family member. So you could make an argument that in this case, you could have treated this non-operatively, but that was not a choice for her. So the question was, how do we fix these? Now, if you look at the fourth metacarpal, it looks reasonable, and there's enough bone on either side to fix it effectively with a plate and screws. But the subcapital fracture of the fifth, to me, was a conundrum because I could not plate it effectively and still expect to gain motion. And trying to treat it non-operatively and trying her on early motion, the fracture site was moving. Could I have put K-wires in it? Yes, but then I couldn't move her. So rather serendipitously, this is what we came upon. And this has created a paradigm shift. So what are we going to do today? We are going to assess indications for intramedullary headless screw fixation. We're going to learn the techniques and evaluate contemporary data and outcomes. So in my mind, as I thought about this procedure when I described it initially 16 years ago, was that the advantage of an intramedullary screw would be fixation in subchondral bone. And because the screws that I used in those days and still use had threads at 2 ends, they gave rotational stability, which would, I was hoping, allow me stable fixation for early movement and was minimally invasive. And in my mind, I rationalized it by saying that the metacarpal head was the same size as the scaphoid. When I looked at the lateral radiograph, I realized that the dorsal third of the metacarpal head lined up very well with the medullary canal. So it was a light bulb going off in my head. And I also noticed that much like any other long bone, metacarpals also have an isthmus, which would allow me purchase with an intramedullary device. And that's how we came about intramedullary headless screw fixation. Now, subsequent studies have shown that the fourth metacarpal is the narrowest and the fifth is widest. And contemporary data suggests that the fourth metacarpal usually takes a 2.4 millimeter screw or slightly smaller. And metacarpals 2, 3, and 5 can take 3 millimeters or more in terms of screw size. And the references are here. So this is what we published, which started this whole paradigm shift. And this was the first case report of this librarian. So here we are, again, to reiterate the case. And after fixation, it looked pretty reasonable. We were able to start her early. She was able to resume her caregiving duties. And at 12 months, was very happy with her outcome. I later saw her 9 years later for another problem. And we can see that she's maintained the durability of motion. And most importantly, the durability of the intra-articular surface, and the hardware looks good. The joint surface looks good. So learning from that experience, I evolved the technique that I'm going to share with you today. So here's someone else, a 38-year-old male who had an unfortunate meeting with the floor, and this was not a self-inflicted injury. And I'll share my philosophy with you about wall punchers later. But the key is you have to meticulously preoperatively template and make sure that the bone is not bent, it's not too narrow, and you have the adequate size screw after you measure the isthmus. So I usually tend to make a small incision over the metacarpal head and the base of P1. It's all done under fluoroscopy. I tend to split the extensor and do a capsulotomy. Occasionally, I will even do a local capsulectomy. It doesn't make a difference. The starting point, as I mentioned before, has to be in the dorsal 1/3 of the metacarpal head. And Jerry Wang's group tend to make a small incision over the metacarpal head, and equates to about 3 to 4 millimeters volar to the dorsal edge of the metacarpal head. You place the guide wire in the lateromedial plane in the center, and in the volar dorsal plane, about 3 to 4 millimeters volar to the dorsal edge or in the dorsal third. And that's why I prefer doing this under direct vision, so I can assure myself I'm doing it once and doing it right. It's then with the Joss maneuver, you reduce the metacarpal head to the metacarpal shaft, and you put the guide wire across. And the good news is that the guide wire actually looks, it maintains a reduction very nicely. And after you confirm the position of the guide wire in orthogonal views, I drill it across the CMC joint so it does not come out with the drill. I prefer using a drill because most of these injuries, as you know, are in young, hard bone. And sometimes the screw can bind as you put it in if you're not drilling it. So I usually use a drill. I make sure that when I'm drilling, I start the drill when the drill is still outside the bone. Now you have to remember the guide wire is only 1.1 millimeter in these screws. So if you were to place the drill on the bone and then start drilling, any slight change in angle and the wire will get sheared off right away. Therefore, I try to start the drill in the air and then make sure I'm perfectly collinear with the guide wire as I go into the bone. Now, what you're going to see in the picture on the left of your screen is that my left thumb is holding the digit down. And why do I do that? A, because it is also doing the Joss maneuver for reduction. And more importantly, B, as the trailing threads of the screw engage the metacarpal head, they impart a rotational torque on the metacarpal head. And you don't want to leave the patient with a rotary malunion when you do that. So my left thumb is controlling the digit and not allowing that rotary torque to happen on the metacarpal head. You then confirm that your screw is subchondral in the PA view, and you also confirm that the leading threads have engaged the isthmus. And here's the postoperative x-rays of that same patient, and it shows that you got good purchase all around. And at 6 weeks, this is what you can expect for an outcome practically every time. So that was an application that was initially utilized for describing this technique by me. But then since then, indications and applications have expanded, which is naturally expected when you look at what happens to techniques when they're described. You can use it in multiple displaced metacarpal neck fractures using the same exact technique as before, and you can see the outcome again. I have also since expanded the technique to include multiple metacarpal shaft fractures. And what you're going to notice here is that the stitches are still in, and look at the amount of the motion that the patient already has. So you can really get rapid rehabilitation very quickly with this technique. I have since also expanded it to include in mutilating hand trauma in this young man who had an unfortunate meeting with a wood splitter. And when he came in, you can see that his fingers were dysvascular. That was his radiograph. And it was decided in the interest of the injury that we would sacrifice the small finger. And we fixed the middle and ring fingers with metacarpal, with these screws. And for the index, I used threaded K wires, which I withdrew later. But by doing it this way, it allowed the fixation to be done within about 15 or 20 minutes, allowing us to get on with the more important part of the case, which is the revascularization of the digits. This is at 6 weeks, and his function is pretty reasonable. And later, he went on to develop much more motion. Now, just because you have an intramedullary screw doesn't mean that's the only way to fix it. You can combine techniques. If I find that the intramedullary screw, which was in this case not the right size, because no other sizes were available, it is okay to combine techniques. And I use threaded K wires quite frequently. As my residents and fellows know, I call threaded K wires the best kept secret in hand surgery. Again, you can drill it at low speed because they go very quickly. and then you can cut them flush, so you can get one more point of fixation in the medulla. And it gives you what I since realize is now described as the kickstand technique, which I didn't know when I did this case. And it gives you one more point of fixation and good intramedullary fixation. Well, what do you do about the comminution? Well, you neutralize that using this, what is known as the sidewinder technique, which is a wonderful application of basically tension band principles, as you can see in this case. If you have head-splitting fractures like this, you can do the same exact thing. Once again, I've utilized threaded K-wires to provide additional rotary fixation intramedullary and liberal use of the sidewinder technique. Now, the sidewinder technique is not something I described. It was wonderfully described by Bob Belsole and Tom Green nearly 40 years ago, and I believe it should be part of the armamentarium of every hand surgeon because it is simple, it's low profile, it's cheap, it's quick, and it's very durable. What are the other described applications? Well, this technique has been used with Volant as well as for malunion correction, non-union correction. It's also been utilized to fix CMC fracture dislocations. I'm not entirely certain of that, but it's been described. P1, P2 fractures are also being fixed by this technique. And most recently, a paper from Brazil has also used this for fixation and after curettage in enchondromas. No technique is without its criticisms, and rightfully so. One of the criticisms is we create a hole in the articular cartilage. Oh my goodness, that's blasphemy. What will happen? There'll be arthritic change, and it may cause compression and shortening, and there won't be any rotational control. But in defense, metacarpal head size, like I said, in my rationale, was similar to the size of the proximal pole of the scaphoid. We use chondral insertion sites everywhere else. We use it in the capitellum, we use it in the tibia, we use it in the femur, we use it in the scaphoid, we use it in the radial head. So why can't we use it in the metacarpal head? The bipolar threads, in my assessment, give me rotary control. And whenever you have a problem that faces questioning, it is always good to go to the lab and test the theory. So that's exactly what we did when we did a quantitative 3D CT analysis of this technique. And what we did was we looked at the surface of the metacarpal head and the surface of P1 and tried to find out how much of the mated surface area was actually involved when you put your screw in the dorsal third of the metacarpal head. And what we found that the amount of articular surface involved with a 3 millimeter headless screw was only 12% of the articular surface and counted for only 8% of the coronal mated plane and 4% of the sagittal plane. And that's because metacarpal phalangeal joints have 30 degrees of hyperextension available, which is almost never utilized for most functional tasks. So that's how we can get away with this technique. So what does the data tell us? Well, since I first described the technique 16 years ago, it appears that if you put intramedullary headless screws and metacarpal into PubMed and you search, it shows up 62 papers with over 1,300 fractures treated worldwide. And most studies conclude that the functional outcomes are excellent and rapid, with a very low rate of complications. And not surprisingly, it appears that larger screws are stronger. For example, a 4.5 millimeter screw is twice as strong as a 3 millimeter, but the authors rightfully caution that the articular cartilage defect is obviously also larger. Now, is this technique biomechanically stable? It appears that based on most studies that it is biomechanically stable and compares very well to K-wires as well as plates, but acknowledging that plates and screws in the right indications are far more stable. It's only John Capo's group which has found that this technique is not as stable as crossed K-wires as well as plates and screws. And that's certainly a good conclusion. But in defense, I would say that most of these studies are done in vitro using cadavers. And the kind of flexion forces that you generate in the lab are, in my assessment, and perhaps I'm biased, these forces are unphysiologic and not generated in the human hand in the act of doing simple composite flexion. In addition, Mike Rivlin's group also looked at percutaneous insertion, and they concluded that the tendon trauma is quite minimal and is not significant enough to cause concern. My personal series, which we published a couple years ago, in 12 years, approximately 40 to 45 fractures. All had wonderful motion with total active motion in excess of 240 degrees. But I did have one bent asymptomatic screw. This is how the patient looked when he had healed. And later, when he came back to get clearance to join the armed services, X-ray showed this, when he sheepishly admitted that he had struck a wall again. So what about the complications? Well, we looked at a multi-center study where we looked at 160 fractures, and we found that there were only 4 complications, 1 nickel allergy, 2 bent screws, and 1 broken screw for a complication rate of 2.5%, which compares very well with the other studies which show complication rates which are similar. We talked about percutaneous screw fixation. We talked about mini open screw fixation. But what do you do with someone like this who is 3.5 weeks out? He's a carpenter. And in this case, I decided to try the technique with formal open reduction internal fixation. And that's exactly what we did, because we could not get a close reduction. If you notice, in the lateral view, the 2 fragments are bayoneted. Therefore, an open reduction was done. And once again, the technique held up. And at 5 weeks, he had full function and was back to doing his job. For those of you who might be interested in reviewing a paper version or a published version of what has just been said in this talk, this paper, which we published not too long ago, covers most of it. So what are the take-home messages or the keys to success? You have to be really careful with your patient selection. And this is where I will talk about wall punchers. I do not use this technique for wall punchers because, just like I showed you before, someone who punches a wall once has, in my opinion, tendency to punch again. So you have to be careful about that. You must template carefully. The dorsal 1/3 is the starting point on the metacarpal head. You have to remember that the 4th metacarpal is the most gracile of the metacarpals. It takes a smaller screw, and the other metacarpals do take larger screws. Does it matter which company screws you use? No, because in my opinion, the intermedullary headless screw is merely an internal splint, and one should not get fixated on compression. Now, always remember those who went before you. So my dear friend, Tom Fisher, sent me this book, which is from 1977. And just when I was thinking that I had really discovered a wonderful technique, he sent me this picture from this book. A headed screw which had been utilized for the same purpose nearly 50 years ago. So always humbling to know that there are people who went before you who thought similar to you. I'll stop right there.
Thank you, Dr. Mudgal. That was fantastic. Could I ask you, how do you do your preoperative templating? How would you describe that to the participants?
I use the system that we have, PACS, and I measure the narrowest portion of the medullary canal in all views, taking the one view where it is the narrowest as the size of the screw I'm going to use. If they have any pre-existing deformity, it's not going to work. You can't put a straight screw in a bent bone. So,
right. Thank you. No, thank you. That was fantastic. All right, next up, we'll have Dr. Yao talk about complications and kind of how to get yourself out of situations that you didn't really want to be in. So, Dr. Yao.
Can you hear me okay? I lost the audio.
No, you're good.
We can hear you. We lost your slide deck.
You lost your slide. You share your screen again.
Okay, sorry. I was in the middle of answering that question in the Q&A. Sorry about that.
No problem.
All right, let's go back to the share screen.
There you are.
Yeah.
Perfect.
Cool. Well, I'm getting this loaded up. Shai, I had a question for you as well. The implants you showed, I think they max out at a certain length. What happens if you have a really long metacarpal? Do you feel like you need to go stem to stern, or do you feel like as long as you pass the isthmus, you're okay, or have enough fixation either side of the fracture?
Yeah, the company whose screws I displayed in all my slides has since I did I won't say complain. I did raise concerns about the max length of the screws. And since then, they have evolved. And now they do produce longer screws. But I don't think it's unreasonable that you don't have to have a screw that goes from stem to stern. As long as all the leading threads are within the proximal fragment and are not going across the fracture site and showing you isthmic purchase, I think you're fine. Right. Again, not to belabor a point, I keep telling my trainees, this is an internal splint. That's all this is, an expensive internal splint.
Thanks, Shai, and thank you for introducing that concept to us, because it really has been a game changer in my practice for sure.
Yeah, thank you.
Okay, so I'll focus on some of the complications that we typically see. Now, I'm not going to focus on standard surgical complications like infection, tendon injuries, anesthetic problems, things like that. We're just going to focus on specifically what we see with the treatment of metacarpal fractures. Here's my conflict of interest slide. These are our learning objectives. Excuse me. And then I like to break these complications down into a number of broad categories. First, unnecessary intervention, and then tendon adhesions, non-union, malunion, and then hardware failure, or arguably the incorrect indication. I'm going to focus primarily on the last one because I think that's the most common out of all of these. So the first is unnecessary intervention. I like this slide because I show this slide a lot, and I always quiz the people in the audience. Okay, what would you do? And people come up with all these creative ways of solving this problem, treating these fractures, X-fix, K-wires, plates and screws, intramedullary fixation. But I like to show this because the first and foremost, when you see a patient like this, don't treat the X-ray, but you treat the patient. And this patient actually had excellent motion, no malrotation. And even though the X-rays are pretty dramatic, this patient could certainly be treated non-operatively. So I would urge you not to take what you learn from this talk and treat every metacarpal surgically if it's not necessary. That's my first complication. Well, not really complication, but my first caveat. My indications for surgery, if there's any malrotation, if the fractures are displaced, if there's multiple metacarpal fractures, as Chai showed earlier, if they're open, and arguably for athletes. Tendon adhesions. This is a very common complication as well. We really want to favor methods of treatment that allow early protected range of motion. And rigid fixation, remember, the higher reduction, the higher the strength of the implant, whether it be plates and screws or IM fixation, potentially or lag screws can potentially lead to greater morbidity with soft tissue dissection, stripping, which leads to tendon adhesions. Typically, the extensor tendon becomes adherent to the underlying metacarpal as it's healing. And you see this most commonly with the plate and screw construct, secondarily with lag screws, then K-wires. And I do think one of the big benefits of the IM fixation is that you can avoid a lot of these issues. You want to try to start active range of motion as soon as possible. I usually start within a week, just giving the patient some soft tissue rest, even if K-wires are used, although with K-wires it does become more of a problem potentially with pin tract infections. But starting early range of motion is the best way to try to prevent tendon adhesions. And if the tendons do become adherent, then extensor tenolysis, plus or minus removal of the hardware that's in there, should be employed. And I usually wait a minimum 3 months, let the soft tissue mature, really let them max out in therapy. And at that point, you do your extensor tenolysis. What about non-union? Thankfully, this is a very uncommon scenario, but when it does happen, it's not very pleasant. I like to illustrate with one of the cases that I've seen in my practice. It's a patient with a metacarpal fracture seen elsewhere, initially treated with this fixation, and 2 weeks later, you can see that this has failed, and you can argue that biomechanically, lag screws probably weren't the best option. Maybe these screws are a little bit small as well. So probably the inappropriate choice of technique. So the same surgeon went back a week later, revised that to a spanning plate. Not bad, looks okay. But then 2 weeks later, and it shows up with this scenario. So then the patient came to me and I said, okay, I can fix this problem. So I put a stouter plate. This is a 2.4 millimeter plate, I believe. And I thought I was a savior. Got a line, got a stout plate on there. I was high-fiving everyone. We thought we had a victory here. But lo and behold, 2 weeks later, the patient showed back up in my clinic, and this was devastating. Then we identified that the patient who's a rheumatoid arthritis patient was taking chronic NSAIDs. And I know the literature is somewhat controversial regarding NSAIDs and bone healing, but we had the patient stop NSAIDs, and we revised the fixation, an even stouter plate. And this time we held the metacarpal in place by pinning it to the adjacent metacarpal heads. I basically threw the kitchen sink at this. Of course, each time autologous bone graft was used to augment the fixation. And luckily, 1 year later, she ultimately healed. Of course, she came to see me because she had this other fracture, which is a whole nother ball of wax. But the bottom line is, thankfully, she fully healed. But the point here is that you could argue that with multiple surgical procedures, you're going to lead to a dramatic amount of soft tissue stripping, devitalization of the bone. The bone itself, to begin with, has very little medullary canal, very little cancellous bones, especially through the isthmus, especially with the ring finger because it's the thinnest metacarpal of all. And so you have to be really cognizant of the biology when you're taking care of these fractures. So when it comes to non-unions, there's really biologic factors and mechanical factors. And the biologic factors, again, as we just talked about, soft tissue and periosteal stripping, you want to try to minimize that, particularly if you're doing a plate with screw construct. Remember, the ring finger is the thinnest metacarpal, so there's very little cancellous bone here. So this is arguably a setup. Then the further going down the road is the fact that this patient had multiple procedures. She had rheumatoid arthritis. And then the question of NSAIDs. And again, I'm not going to die on the sword here regarding NSAIDs, but if I have a choice of a patient who has a metacarpal fracture of a pain regimen, I tend to use acetaminophen than any NSAIDs in terms of pain relief. What about mechanical factors? You can argue that at least in the beginning of her care, there was inappropriate hardware that was used. The screws are too small. As Kim presented, you want the fracture to be at least two times the width of the metacarpal or the bone that you're treating. And arguably that was a very short oblique fracture. And so probably not the best indication for use of lag screws. Then there's a concern for insufficient protection during the healing process. If you start early range of motion too quickly, then there's that fine line between avoiding one complication, which is the adhesions, versus the other complication, which is your hardware failure. So we always walk that tightrope between the two scenarios. What about malunions? This is also luckily not that common of an issue. This is a patient presented me who was neglected for a long period of time. Thankfully, the CMC joint was not particularly painful. It was mostly the deformity at the shaft of the metacarpal. And just like any other malunion, a corrective osteotomy can be performed. That's what we did here. We realigned it, took intercalary tricortical graft, and put that as an intercalary graft. You could see that we use K-wires to stabilize the graft and use a bridge plate or a neutralization plate to hold everything together while it healed. Most of the times for malunions, you're going to treat them for malrotational malunion. And that you could do either a step cut or a transverse corticotomy and derotate the metacarpal and then plate it. With the last few minutes, I'd like to focus on kind of the hardware failure / incorrect indications. And so I think this is something that we unfortunately see relatively frequently, either in our own practice or referred to us by other practitioners. Here's a patient of my own, and I own this patient. This is especially since he's one of our anesthesiologists, so I see him all the time. He usually staffs many of my cases, and so he was involved in a bike crash, and you could see he has two fractures, one more dramatic than the others, the index finger metacarpal and the small metacarpal. He came to see me. I was all excited. I thought for sure I'm going to be able to help him. A slam dunk. This is when fixation was becoming more popular and vogue, and I really felt good about it. I thought I was going to get him back to being an anesthesiologist and riding his bike very quickly. So this is what I did. And so you see these intramedullary nails in the small finger metacarpal and the index finger metacarpal. And in retrospect, this is a length unstable fracture of the index finger. You can see there's really no cortical contact on both the radial and ulnar aspects of the index metacarpal. And my start point on the head of the metacarpal is 2 radial. And so at 2 weeks, maybe a problem's brewing, but at 4 weeks, you definitely see a problem here. So you could see the shear component of the fracture is leading to the metacarpal head to drift proximally and ulnarly, and hence the implant is becoming prominent. And this is a problem, of course, because he's looking at me over the drapes every single day, and now he's got this complication. So we casted this patient. We didn't let him move the index finger. He was experiencing mechanical symptoms of the proximal phalanx articulating with that implant whenever he tried to move his MCP joint. So we casted him so he wouldn't move that and let the fracture heal in situ. Luckily, he had no malrotational deformity. He's certainly short, but we accepted that and left the screw until it healed. 6 weeks, we felt it was pretty well healed. I don't have it here, but we did have a CT scan to confirm good bridging. And also clinically, he was not very tender. He was non-tender, I should say. So we felt confident to move forward with the removal of the hardware and to let him start moving. And this is what he had 6 weeks after his removal. And his range of motion actually restored to quite very close to normal. So he's quite happy with that ultimately. But as you can imagine, it was very awkward in the initial go. So the point here is that as much as we rely on these implants to help us stabilize these fractures, we need to make sure that they're done the correct way. We can't blame the implant itself when we have complications. I own this one that the implant was inserted 2 dorsal and 2 radial, and therefore there was not enough fixation or not enough fixation of the distal segments, and that's what led it to fail, especially since, again, after these fractures, I let them start moving immediately. So this is a couple of papers. I think Chai may have alluded to some of these, but there's a couple of papers, systematic review of almost 900 fractures, 0.4% screw protrusion. But union of all fractures at 5.7 weeks. And then another Paco del Pinal's paper of 69 metacarpal and phalangeal fractures treated with the intramedullary screws. The bottom line of both of these papers suggests that you should not do IM fixation in long oblique fractures, such as the one I had, and with lack of at least one cortical continuity, one cortex in continuity with diaphyseal fractures. And also recommending against IM fixation of subchondral fractures, which could lead to head splitting during insertion. So you might also consider, and Shai showed a nice example of this, using an axial strut for a length unstable fracture. So an oblique implant, whether it be K-wires, a tension band, a sidewinder, or another screw to help stabilize that length unstable fracture. So definitely something to consider when you're doing these more challenging fractures. Obviously, for a transverse fracture, this is a diaphyseal fracture. It's a slam dunk. I think for me, my indications for using IM fixation are pretty much for any fracture except if it's too proximal at the proximal base. I think it's very difficult to gain fixation. But you can do subchondral subcapital fractures using IM fixation as long as you put the implant in the right place, which I clearly failed with in that last case. So to summarize, I think these are the main categories of complications that you'll see with metacarpal fractures. Intervening when you don't need to intervene, tendon adhesions, non-union, luckily very uncommon, malunion, slightly more common, but I think a common thing that at least we see in our practice more and more frequently as more and more people are getting bolder and bolder with their fixation methods is the hardware failure and the incorrect indications. So my take-home messages are, to, number one, identify the appropriate treatment for management. Again, remember, close treatment is still primary for most fractures, unless there's malrotation in my hands. My surgical indications, again, malrotation if the bone is irreducible, like I think Kim or Chai showed that one case with that butterfly fragment inside. If you can't reduce it, then open reduction, I think, is reasonable. Multiple fractures, as we saw that one patient with 4 metacarpal fractures, I think that's a great indication for surgical intervention. Any open fractures, and again, I think athletes, in my practice, we almost always treat surgically because it gets them back on the field sooner. You want to favor the most stable fixation that's also the least invasive, and that's why, as Chai presented, IM fixation is that sweet spot. It's very stable, but also less invasive than plates and screws and lag screw constructs, and it's implanted, so you avoid the same issues that you might have with K-wires. You really should encourage range of motion early to avoid adhesion formation, and obviously, if complications arise, you want to identify and treat them as soon as possible. And that's all I have. Thank you very much.
Right. Thank you very much. That was wonderful talk, Dr. Yeah, thank you. We do have a question on the Q&A that I wanted to put as a live answer. And the question is, is there a general rule for the appropriate screw size? And this is, Jeff or Chai, either one or both. Can you kind of think of it that way, or is it just something that needs to be individualized?
Go ahead, Chai.
Do you mean screws for intramedullary fixation or screws for interfracture?
The IM, the intramedullary.
The guidelines that I put up in my slides are reasonable guidelines where you use the smaller screw for the 4th metacarpal and larger screws for the other 3. That being said, you cannot compare the metacarpal size of, let's say, a 4'8" female with someone who's 6'9", a basketball player. It's very hard to. That's the reason I say you can have broad guidelines, but at the end of the day, it's got to be individualized with careful templating.
Right. Yeah. In general, the ring finger is the smallest. And I think Chai had that nice slide which showed that for the most part, the second, third, and fifth all take the same size, and the thumb too. I've actually done this for thumb metacarpal fractures as well. You could use a 3.5, even a 4.5 millimeter screw sometimes. But the ring finger is usually the smallest, and then usually a 3.5 or a 3.0 for that implant, for that metacarpal. And that's why the templating is very useful if you have whatever imaging software you have to measure the isthmus of the canal.
Right. Thank you very much. All right. So I think we'll then transition to Heather and have her kind of tell us what we could do better from our rehab protocols to help our patients have the best outcome possible. So if you want to share your screen, Heather. Perfect.
Okay, great. Well, thank you so much for the opportunity to speak with you all this evening. It's my pleasure to speak with you on the therapist perspective on metacarpal fractures. So as we have already sort of touched on already, the fractures account for nearly 1/5 of all of the hand and forearm fractures that occur in the United States each year. Usually when it comes to metacarpal neck and shaft fractures, we see those most often on index finger through the small finger, whereas the thumb is usually more fractured at the base. So as a therapist, when I receive a referral for a metacarpal fracture, I typically am looking at a couple of different things. The first thing that I look at is where on that bone is that fracture occurring? And that's really important, not only for how am I going to splint that fracture in the clinic, but also how am I expecting that fracture to go ahead and rehabilitate? Is it going to stay stiff, like what you usually see for a metacarpal head fracture, where maybe getting that passive flexion is going to be a little bit more troublesome? Or are you going to have a little bit more mobility if you're seeing it kind of mid-shaft? Maybe it wasn't surgically managed and the patient is young and they're moving well. Another thing that we typically look at as well is, okay, is it extra-articular versus intra-articular? So typically, extra-articular, I'll see more often managed non-surgically. And the really neat thing about that too is that there's a push towards moving away from, all right, so all fractures of the metacarpal needs to be immobilized one joint above and one joint below. Oftentimes we can get away with even just a simple functional fracture base where we're really just providing that support right where that fracture is occurring. Whereas with an intra-articular fracture, that typically I see managed more surgically. And so you have that trade-off because with a surgical fracture, as we've already touched on earlier, usually we can get them moving. That affected joint can get moving a little bit sooner. However, now we're also looking at the most common complication that I see as a therapist come through is that EDC tethering, that scar kind of coming in and tethering that EDC. So maybe they'll result in a little bit of a lag. But regardless, literature is saying now that, with immobilization beyond 4 weeks for a fracture, really that can be quite detrimental because not only are you impacting that patient's connection of brain to hand where they're learning, okay, I can actually get away with only using one hand, but also bones respond nicely to a little bit of stress. So here's our timeline that we usually follow. This is showing you about the difference between open reduction, internal fixation, and also closed reduction. So again, open reduction, it's great because we can usually within that first 3 to 5 days get that patient moving. The neat thing as well is that we can actually have that patient begin self-passive motion, which is typically very safe, not only because it's not the therapist that's providing that passive range of motion, but the patient, so they can stop when they start to feel, anything past just a stretch. Typically in my clinic, I'm really blessed in that I'm able to go just right across the hall to our surgeons and communicate directly with them, make sure that they're okay with the self-passive motion, but also the knowledge too that usually when you have passive flexion, that actually serves to compress the fracture, which can be inherently stabilizing for that fracture. Then looking at that 10 to 14 days, that's where if we're seeing a lot of stiffness resulting, that we can look at, all right, maybe we need to make them a dynamic flexion orthosis. I'll touch on that a little bit more in later slides, but it can seem very aggressive at first. The cool thing about a dynamic flexion orthosis is that it's designed to be worn over a long period of time. So we're not looking at having them just kind of pushing down and maybe they're going a little bit too rough and pushing a little bit too hard, but it operates off the principle of soft tissue creep, which means that you're holding that joint in its end range over a prolonged period of time, typically 15 to 30 minutes, and you're waiting for, the soft tissue structures to kind of elongate, and patients can tolerate it actually almost a little bit better. And then looking at that 3-week mark, again, you get to start to actually have the patient begin that light ADLs outside of the orthosis. Usually around 8 weeks is where we see a matching in that timeline between closed reduction and open. Patient can begin strengthening with 10 weeks normal use of the hand. So common complications from my side of things, I actually don't see as much that delayed union or that non-union or infection. From a therapy perspective, I'm seeing more scar adherence, whether it's surgical, again, that EDC is tethering, or you're seeing the fracture callus, for conservatively managed patients that aren't surgically managed, maybe that one wound, one scar, that fracture callus is actually because of the EDC and its close proximity to your metacarpal, maybe they're becoming a little bit tethered down in that as well. That can usually result in that extension lag. But of course, the knowledge being that with any fracture of your metacarpal, typically the intrinsic muscle is that deforming force. Fractures that are displaced dorsal or volar, we see in the clinic a little bit better tolerated by the patient, rather than a rotational displacement, which brings the fingers away from the thumb. Patients typically have a lot more difficulties with that because it affects the functional use of their hand. With that dorsal or volar displacement, if they lose a little bit of length, I'll get a lot of questions of, I used to see a prominent knuckle here. I'm not seeing that as much anymore. So usually just reassurance that that's okay. And usually these people still have good functional use of their hand. And then also keeping in mind that multi-tissue trauma is a real thing. If you have a fracture, if you have a force that's strong enough to displace a bone, then you can be sure that there's going to be trauma to that surrounding tissue as well. So when we receive that referral for a metacarpal fracture, first thing I like to look at is the x-ray. And if I'm lucky, I get to see pre-reduction and post-reduction because that tells me, all right, how did the bone fracture? How much did that fracture displace? Where on the bone is it fractured? So Usually from the therapy side of things, I know, all right, if it's fractured at the head or the neck, it's going to require a little bit more effort in getting that metacarpal to achieve full passive flexion. Also knowledge too that transverse mid-shaft fracture, I usually see it to be maybe a little bit slower to heal. So I'll keep a closer eye for a delayed healing and malunion or a malalignment of the digit. If that patient remains stiff and I'm going to be starting to use more of the conservative, maybe some joint mobilization, some techniques in the clinic in order to get them moving, it's also important for me to know, okay, is it an oblique or spiral fracture? Because that occurring in the mid shaft will usually displace a little bit more easily with compressive or rotational forces. Whereas if I have a transverse fracture in that same location, then that's going to displace a little bit more easily with manual therapy techniques that involve traction, which is something that we do a lot in order to get those tight collateral ligaments to sort of relax. I also want to know, is it comminuted? Because of course that has an increased risk for persistent or recurrent fracture displacement. How are they moving? Do they have intrinsic tightness? Oftentimes patient, when they're bringing that hand down, what they'll do is they will pop that metacarpal back into extension and then just rely on IP flexion instead. So I want to see how they're using their hand. And then also, what is the priority of the patient? Are they retired? Are they a farmer? Are they an athlete? How is it that they use their hand day-to-day basis? Because really, therapy can change a lot based off of that. So rehabilitation pearls, this is usually what therapists will do in the clinic in order to get that optimal outcome from a metacarpal fracture. So biggest thing that we see, again, it's the EDC that tethers onto that scar and that can result in an extension lag. If you look at the upper left-hand corner here, that's a patient doing one of these EDC glides where we're really isolating that extensor tendon and asking it to move through that full available range. Another thing to keep in mind too is that if we have a patient that's really stiff into flexion and we're going to start to go after flexion a lot more aggressively, then we're going to want to make sure that we balance that out with extensor tendon training. So making sure that we're not focusing so much here and progressing them so quickly that they begin to lose straight, because the knowledge that scar tissue is collagen, it's just that the collagen really doesn't have as much elasticity as the rest of the skin. So we're not so much breaking up the scar tissue, it's more that we're encouraging it to lengthen and move with the patient's native tissue. Malalignment of the digits. So scissoring, we usually treat that through buddy taping. Interestingly enough, Hong and Associates in 2022 did a study where they had cadavers and they gave them all a simple transverse mid-diaphyseal fracture in the ring finger. What they were looking at is there a way to prevent that malalignment of the digit for conservatively managed patients? So in some patients, in some cadavers, they used a 2.5, a 5, and a 10-pound weight to kind of simulate how a patient is casted in that same safe position. And then that, that force that's pulling them out. And it was found that when you have just the two fingers, just a ring and small, that there is a positive correlation to having this rotational displacement, and that it's greater when the force is applied to two fingers versus three. So if you're worried about the location of the fracture, you're thinking, okay, maybe they will have a malalignment of that digit, it's safer, as proposed in this study, to actually include that middle finger so that the patient doesn't end up having that scissoring. And then just continued rehabilitation pearls, looking at that upper left-hand corner, that's a splint that we'll typically make. Again, IPs are included in that splint, but that doesn't necessarily always have to be. It really varies based off of where that fracture is occurring. And not all patients actually are even in that safe position. Sometimes based off of the deforming forces on that bone, we'll actually put them in extension because it's safer for them in that way. And so you're really wanting to look at that fracture and determine, all right, what do I want my therapist to build so that they're safe, but they're also moving? On the bottom left-hand corner, that's where I was talking about before, that dynamic flexion orthosis. That's just an example of something that we built for a patient. And then also, the cool thing about splinting as well is that we can really rely on some principles. For instance, there's one that's casting motion to mobilize stiffness. So patients that don't use their metacarpals, they don't drop those down, and they're only relying on those IP joints. Sometimes I have immobilized the IP joints and had them go away for a week and use their hands, so that now, because they don't have this, they're having to move that metacarpal down. And then, of course, the last one being pain. Pain is a common complication. And sometimes even just coaching the patient that they can provide that stability or that support right where that fracture is, or even building them a little support orthosis while they're doing their exercises can be really helpful for them. So case study, I treated a 31-year-old female. She works as a social worker. Unfortunately, she sustained a skiing accident, and it resulted in a fourth metacarpal shaft fracture, a couple of CMC dislocations, and then a thumb metacarpal fracture as well. She went on to undergo open reduction internal fixation and pinning of these fractures and dislocations. And in therapy, we needed to make that dynamic flexion orthosis. But the reason why I am presenting on her is that, as you can see on the left side of the screen, she came in pretty stiff, and she definitely had extensor tendon lags across all of her fingers. And I think that was really due to her scar. She had quite the scar. And really a good way for us to evaluate that is just pinching the skin, seeing if it forms a little bit of a peak or that mountain, but instead it tethered down, formed that valley, and the scar was really not moving. So of course we did a lot of scar mobilizations. We got her into some heat just to kind of relax her and allow her to tolerate therapy a little bit better. But the reason why I'm presenting particularly on this case is that I was able to go across the hall and say, hey, listen, I know it's only 2 weeks out, but she's really stiff. I'd like to get her going. Can I get her into that dynamic flexion orthosis? Surgeon said, yes, that's fine. She's stable enough. We got her going. And then, within a few weeks, she was able to achieve that full composite fist and full extension. I think she had a tiny bit of a lag at that ring finger, but was continuing to work on that. So final points, just to wrap up. The biggest things from a therapy perspective is early motion. We're going to take advantage of that whenever we can and really push for that early motion, because we need that, that gliding of the EDC, and we want to avoid any sort of, intrinsic contracture. If they're not able to get that final tuck, then that could be because those lumbricals are a little bit shortened. And so trying to get them back so they're able to stretch and get that final tuck of their eyepiece down into their hand. And also intentional immobilization. So I think that there can be a little bit of a push for, all right, so we see a metacarpal fracture, let's send them to therapy, forearm base them, spike it to the tips. Where really, if you're looking at that fracture, it can be so helpful to say, well, actually, do I really need to immobilize them? And that's not only looking at the fracture, but looking at the patient. The hand demands of a patient that's maybe in their 90s is going to be a lot different than, a patient that's in their 20s and 30s. And so if we can give them even just IP joint motion, or, maybe even let their metacarpals come out completely, if it's really near the base and you're feeling solid about how it's healing, then you're reinforcing that brain to hand connection. You're encouraging the patient to use their hand in a safe way, and then you're getting those structures gliding. And then as a final point too, communication is so key. As a therapist, that's something that I love, because I feel comfortable approaching the surgeons and saying, all right, I want to get this patient moving. What can I do safely? Because you want to see that progress from visit to visit in order to have a successful therapy outcome. And there's my references.
Oh, that was so wonderful. Thank you, Heather. That was so informative. I appreciate that. One question for you is, one message you could give your referring surgeon that would make your life better, what would you tell us?
Ooh, I have to narrow it down to one, and that's a little bit.
That's all. We only have time for one. I'm sorry. No.
Yeah, that's fair. I think that I would say that the most important thing is to be available to your therapist. And it's interesting because you would think it would be more of, all right, always do this with this patient or always do that. But really it's not that much. It's more of establishing that open line of communication with your therapist. I've worked in hospitals where it's a really hard job for me to even just flag a surgeon down because they're in and out of rooms, and I'm just trying to ask, hey, can I get them into this flexion orthosis? I'll take 5 minutes of your time. So just really establishing that good rapport with your therapist, because we, at the end of the day, just want to get the patients better. And so if we feel comfortable approaching surgeons saying, hey, we're in this together, we're both working towards the same goal, then we're going to want to approach that surgeon more often and really feel comfortable with getting that patient moving. So I would say communication, honestly, is probably the biggest thing.
Great. We have a question for you from the participants. The question is, why do you choose a dynamic versus a static progressive flexion orthosis for these patients?
That's a really good question. There is actually a study that was released looking at, all right, how do you establish what sort of splint you want to make? And I would have to pull up the box. But basically how you look at this is, if you have a patient coming in, they're very stiff, what you're going to do is you're going to take them through, you're going to measure them, and then you're going to take them through a full therapy session. You're going to do heat, you're going to do stretch, you're going to do some functional activities, and then you're going to measure them again. And so usually if they make between 0 and 5 degrees of progress, then you know you're going to go actually even static progressive. You know, you want that force. If they're going to do 5 to 10 degree increase, then you know maybe you can do more of a dynamic component, and 10 to 15 degree increase. Usually they say, actually, you probably don't even need this orthosis because it is time consuming and it is an expensive, intervention for that patient. So there's a really great, if you look it up, you can find it online. And it's just this awesome study that was released of, okay, what's the algorithm to determine what that patient needs?
Oh, great. Thank you. Thank you. I think we have time for one more question. Shai, this I might direct to you. As you're doing the intermedullary screw, kind of a two-part question. How do you prevent the fracture site from being distracted during the placement of the screw? And what happens if the screw gets incarcerated? What do you do? How do you salvage that?
So let's look at the first one first. How do you prevent distraction? Well, when I started originally doing this, to me, unless you drill the entire length of the metacarpal, I think you're going to run into trouble because most of these fractures are in young, healthy males, which means very hard bone. And the endosteum is no less forgiving. So that's the reason I drill it. And if you drill it, and like I showed you, my left hand is holding or right hand, as the case may be, is holding the fracture reduced. At the same time, it is also applying a gentle reduction force, if you want to call it that. And it doesn't distract if you drilled it before. If you try to, these screws are meant to be self-drilling, self-tapping. Don't believe that. That's good to know,
really helpful,
but that's not good to apply.
Fracture angulation, talking just as a guide in these diaphyseal fractures, starting from index to small.
Answer to number
10 degrees, 10 degrees, 20 degrees, and 30 degrees on the small is kind of a good guideline to just think about.
I think that's
use that to help you make your decision.
About as much as we can get to
and again, 10 millimeters of shortening, which in some series that said that you could accept that. 50% loss of power, which is probably not going to be acceptable to most patients.
I think we had a great discussion.
Just a last slide on outcomes, just talking about basically what do we expect.
We have another session coming up
Dr. Stern showed that about 36 complication rate with fixation, open fixation of metacarpal fractures, but 76% good and excellent results. The range roughly is about 20 to 35% complications, most often notable stiffness, strength changes, and need for hardware removal. Dr. Mudgal and his group published a series with plate fixation and showed that 18 out of 19 of them patients had full